So I thought today, while this is connected to your heart, I think what we're going to talk about today is a thing that's kind of underappreciated, underdiagnosed, but is every bit as much of a problem as heart disease. And they're really connected because people with heart disease have this problem as well. And people that have this disease are more at risk to have heart problems. And so it's kind of something that we don't think about. Don't take this the wrong way, you know, sometimes as we get older, well, this hurts a little and my legs hurt a little and can't get around like I used to get around. And so sometimes this particular problem goes highly undiagnosed because you just kind of say, well, you know, that's life, right? That's life. I'm a little stiffer and I'm a little slower than I used to be, but it doesn't necessarily have to be that way. So what I want to talk today about is peripheral, you'll see it called both things, PVD, peripheral vascular disease. Specifically, I want to talk a little bit about peripheral arterial disease, but the two are really used interchangeably. They're not that much different. So, peripheral arterial disease, again, PVD, PAD, you'll see both. So it's caused by the same disease process that causes hardening of your arteries, atherosclerosis. So when you hear people say, oh, there's some plaques in your arteries, or we did an arteriogram and we saw some plaques there, that disease is called atherosclerosis. And it means kind of hardening of the arteries. But what it really means is that cholesterol and things get built up on the insides of your blood vessels. Now, there is a thing called chronic venous insufficiency, and I'm going to show you a couple of, you know, if you need to shield your eyes, pictures it's to help show you the difference. So you can get so basically we say atherosclerosis starts in your heart, so that's heart disease. And then peripheral vascular disease is kind of everything else. Legs, carotid arteries, kidneys, abdominal vessels, everywhere. So we're going to spend a lot of time today on legs particularly, but I also want you to know that it can happen in other places. It can happen in the aorta, which is the big tube that heads out of your heart and then goes down into your stomach and feeds your legs. So it can kind of happen everywhere. So this is a picture of somebody that has chronic venous insufficiency. And I can give you a whole hour-long lecture on this, but we're just going to touch on it briefly today. So in chronic venous insufficiency, the veins are bad. So remember, arteries take blood away from the heart. That takes blood that's got good oxygen in it and takes it to your tissues. Veins collect the blood after it's given off the oxygen, and the blood goes back to your heart. So in your legs, we have arteries. They go down to your feet. The blood goes back up in these veins. Now, veins are a little funny. Arteries have muscle around them, so arteries can kind of contract and push the blood forward. Veins don't have any muscle around them. They're very thin-walled, and they actually rely on your legs, the muscles of your legs, to kind of milk the veins to get the blood back. And so veins have little valves in them. And so when your muscle milks the vein, the valve opens, it allows blood to go up, and then the valve's supposed to close so that the blood doesn't come leaking back. Well, over time, those valves can become incompetent. And so if you have completely incompetent vein valves, then you get what's called varicose veins. You've seen that with those big ropey veins in people's legs. And so if you look here on this picture, you can see these bulgings right here. Those are the incompetent veins. And so frequently, you can see them all kind of swollen up here. You can actually get chronic venous ulcers from long-term venous insufficiency. I think the other thing you should notice is kind of the chronic discoloration of the leg, right? It doesn't look the same color as the skin up this direction. And so this is treated in a completely different way. And again, we can get into that in another talk, but I wanted you to know what chronic venous insufficiency looks like. It tends to cause chronic swelling in the legs. You may have to wear compression stockings, things like that. Now, peripheral arterial disease, on the other hand, is when you're not getting enough blood down to the ends of the blood vessels. So you can see, you do see some, sorry, I got my buttons messed up. So you do see some discoloration, some chronic discoloration, but you see how it's more here out on the end of the foot, because that's where the blood's got to get to and it can't get there. You can see some kind of color changes of the nails from that. What you don't see, so you can still see the bones here. What's that? That's not part of the presentation. And you can still see the bones here. So you see the foot's not that swollen. And the other thing that you can see that you usually see on a normal foot, there's no hair on it, right? The hair is all bone. Because the body says, well, gee, I can't get enough blood to keep the tissue alive. Why should I spend time growing hair? So you'll see, a lot of times you'll see a fairly skinny extremity, and you'll see it with kind of shiny skin. It may be a little discolored, and frequently all of the hair will be gone. So let's just briefly go through different areas of peripheral vascular disease, and then we're a little more time, particularly talking about the legs today. So one area where peripheral vascular disease can affect you is in your carotid arteries. So your carotid arteries live here in your neck. You have two of them. You've got a common carotid, and then it splits into two parts: the internal carotid artery, which goes to your brain, the external carotid artery, which goes to your face. And then in the back of your neck, you have two other arteries called vertebral arteries. So we got four arteries that help feed our brain. Where we really get concerned, and where it happens most commonly, is when that internal carotid artery gets a blockage in it. So what you may notice is your doctor may say, ooh, you've got a bruit. So what's a bruit? So a bruit is, I don't know if any of you have been to my office, I frequently will listen to your neck. So I shouldn't hear a sound in your neck when I'm listening to you. And if you have a bruit, it'll sound like this. And that's because the blood is flowing past a blockage. And so the flow becomes turbulent and you can hear a sound. Now, the fact that you have a bruit doesn't mean you've got a tight blockage. It just means you've got some blockage. So you can't tell from the sound, the loudness of the sound, how bad it is. Now, very important, almost universally, blockages in your neck are painless. You don't feel that blockage. So I have plenty of patients that come to my office and say, ooh, my neck's killing me, my neck's hurting, it's hurting, I'm worried I got a block. So that's probably not your carotid artery, that's your spine or your muscles or something, but blockages in your carotids are frequently painless. That's also the bad part about it, because if you don't feel it, you don't know it's there. So if you had some sort of pain that gave you a sign, ooh, I got a blockage, then you might get that looked at. The biggest problem with carotid artery disease is it's highly associated with strokes. And that's why we have to watch out for it. So most frequently, carotid blockage is treated with surgery, a surgery called a carotid endarterectomy. They'll open up your neck right here and clean all that gunk out and then close it back up. Some cases we treat with a stent, but those are for patients that really are poor surgical candidates, or if they've had radiation therapy to their neck, we won't do surgery on those patients. Let me see. So you can see here, so this bottom picture is called the common carotid artery, and you can see it splits into two parts. The one here on the right where the arrow's pointing is the internal carotid artery, and this one's the external, and you can see it gives all these branches off to the face. And you can see right here, you see how skinny that artery gets? So that's a carotid artery blockage. And this one happened to be treated with a stent. And so you can see after the stent was put in, you can see how much flow there is now. The artery actually looks pretty normal. So, but again, most frequently treated with surgery, but there is carotid stenting available. Now, there's a second thing. You can also get blockage in the arteries to your kidneys. This is a disease called renal artery stenosis. Renal artery stenosis is when you've got a blockage in the artery that feeds the kidney. Most commonly, we see people that have very difficult to control blood pressure, or their blood pressure kind of wildly swings. You know, one day it'll be 200 and the next day it'll be 120, and it can never seem to find the middle. So in people that have really wide swings in their blood pressure, And the other very common thing is you may be on a third medicine, then a fourth medicine, then a fifth. You know, we just keep piling medicine on you, but we can't get your blood pressure down. We have to look for renal artery stenosis. Again, painless. You don't feel it. And it may lead to failure of that kidney if you don't get it treated. It's most commonly, we screen for it with an ultrasound called a renal artery ultrasound, and then ultimately you may need to go have an arteriogram done. We usually treat that with stents. Back in the old days, they would do surgery on those, but gosh, I haven't seen a patient get surgery for renal artery stenosis, maybe ever. So if you look here, this is the spine, and this is my catheter. And so you can see the renal artery, and you can kind of get the shape of the kidney here. You see how the arteries go out to the kidney. And you look how nice and big that artery is there, and then you see right there, you see how it looks very small? And so that's called a renal artery stenosis. So remember, these arteriograms that I'm showing you, this is showing you the picture of the inside of the artery. It's like a photo negative. So you're not seeing the walls or anything, you're seeing the empty area inside the tube and where the blood has a chance to go. So you can see a really tight blockage here, and then we treated that with a stent, which is actually fairly simple to do. It takes about 15 minutes in the cath lab, and now that artery's got good blood flow. So most important reason to fix those is because it'll save the kidney. Now, some patients who get their renal artery stented, their blood pressure gets a lot better to control. Don't let anybody promise you that they're going to fix your blood pressure problem by putting a stent in your kidney. It may help, but it isn't going to, your blood pressure is not going away. But more importantly, you know, you can imagine if this thing closed right there, that whole kidney would be dead. So saving the kidney, particularly in people that already have some kidney insufficiency, it's important to open up those arteries. And there's one more. So in this case, you can see the artery here, and you see that the blockage is in the middle of the artery. And again, we treated it with a stent and got back to normal flow. So, quickly on this one, let's go back. There is a thing called mesenteric ischemia. So all your guts need blood. So there's blood vessels that lead to every part of your gut. And so people can get blockage of those arteries. There's three main ones. One's called the celiac, feeds your liver and your spleen and your stomach. There's one called the superior mesenteric artery. We usually call it the SMA. That feeds the majority of your guts, your intestines. And then there's a little one called the inferior mesenteric artery. Most commonly, that blockage occurs in the SMA. And so patients will come in, they'll have unexplained weight loss and almost to a person diarrhea. And the reason for that is the intestines are not getting enough blood. So they kind of shaves off the lining of the intestines, and so then you don't absorb everything correctly. And so patients will almost all present with diarrhea. They'll also have abdominal pain, and it'll be frequently after they eat. This can also be treated with a stent or occasionally with surgery. I don't have a lot of pictures of that. This case doesn't come up often, but I just want you to know about it. So another thing that you've probably all heard of, and it's called AAA. So that stands for abdominal aortic aneurysm. And so that's kind of an outpouching of the aorta. It's most common in the abdomen, but you can get aneurysms up here, up in your chest. So your aorta, remember, starts here at your heart, travels up here, gives off the carotids, which go up to your brain, and gives off branches to your arms, and then it goes down, and then ends up feeding the other organs. It's the main conduit for blood flow. Again, usually painless. I think we're seeing a theme here, right? So pain is not it's not pointing you to that you have this problem. So I actually think that Medicare, if I remember a few years ago, has actually started doing this for people that are just starting in Medicare. They want everybody screened for an abdominal aortic aneurysm, and they do that with an ultrasound. So if you've never had that, you may want to talk with your primary care provider about it, because I think Medicare allows one-time screening for everybody. So that's detected by an ultrasound. Usually the vascular surgeons take care of this. So back in the old days, the way to treat this was not very nice. They'd cut you from about here to here, open you up and fix your aneurysm, and you'd be in the hospital for about 10 days with an NG tube down, and it was very unpleasant. Current technology allows well over 90% of these to be treated with stents. Now these stents are a lot bigger than the ones that I've been showing you up here. I mean, they're big. And so they'll have to usually kind of cut down to the arteries down here in your legs, but they still can kind of put the stent up into your aorta. And most people can be treated that way, and most of them go home the next day. So that's a much better way to go. When we treat those is based on the size. Generally in the abdomen, around 5.5 centimeters is the size. When it gets to that, then the risk of rupture starts to go up. Up here in the chest, we kind of go with 5 centimeters, partly because it's up under higher pressure. These are a little bit in the chest harder to deal with because you can't get to them as easy. And particularly if you have it in the first part of the aorta, sometimes that requires a pretty big surgery to fix. So, but the problem with these is they tend to rupture, right? And if they rupture, it's not a good situation. So you need to know about it before you have it. You don't want to show up with a 10 centimeter aneurysm, or worse if it starts to leak. So this is the picture of an abdominal aortic aneurysm. So you see the aorta coming down here. You see the kidney arteries, which look very nice. There's no renal artery stenosis. And so now you get down here. Now you see how this thing starts to pouch out like a balloon. So what happens is the wall of that aneurysm starts to get thin and it starts to balloon out. Remember, the blood's under high pressure here. The pressure of the blood in there is the same as your blood pressure. So if your blood pressure is 150 millimeters of mercury, 80 times a minute, it's hitting against that wall at 150 millimeters of mercury. All right, so we got to watch those, and we can follow them very easily with ultrasound. So we're going to now go forward to the bulk of what I want to talk about was your legs. So at the bottom of the aorta here, you can see we have a branch that goes to the left leg. Remember, when you're looking at this, this is like if you're looking at the patient. So left's over there, right's over here. So this is the iliac arteries right there. And it branches. That's called the internal iliac. That kind of feeds the bladder and reproductive organs. And then the thing continues here is the external iliac. Why is it called external? Because it leaves the pelvis. And so then comes down here and becomes femoral arteries, and then we have more anatomy below that. But as you can see, there's basically one main conduit that feeds each leg. So what are the signs and symptoms of peripheral arterial disease? So the one you'll hear a lot is a word called claudication. What is claudication? Claudication means leg pain, particularly when you exercise or try to exert yourself. And depending on where the blockage is, depends on where you feel the discomfort. So people that have blockages up here in their iliacs will say, well, every time I hurt, my hips hurt or my buttocks hurts. And so I get plenty of patients who've been to the orthopedic, to the rheumatologist, to the neurologist. You know, I can't find anything wrong. Well, it turned out they had blockage in their iliac artery. And so it's very common for buttocks pain to be, you know, and again, you're walking down the street, when you stand still, everything's fine. So claudication kind of means exertional symptoms. So very frequently patients will say lost exercise capacity. I can't do what I used to do. It can be ulcerations. We want to try and catch it before you can get an ulcer. The chronic skin changes like I showed you in that first picture, and then again, loss of your skin appendages. The hair on your legs tends to fall off. So what do we see when we're looking? So what we want is, we want to be able to examine your feet. So the most important thing, remember there's one road that goes to each foot. Now it splits into a lot of different blood vessels, but there's one road, that iliac artery. And so very frequently we will want to check the pulses in your feet. So you've got 3 pulses in your foot, one on top of the foot and one on each side. And so we want to look and make sure that there are good pulses present. We'll see shiny, tight skin. You saw this in the picture, how that skin appeared a little dusty out there at on the toes. And so it can get so bad that you have ulcerations, or if you lose blood supply, you might have a black toe because that toe has now died. unfortunately. The other thing that we want to look for, and this is really key in our diabetic patients, because diabetics, they don't heal their wounds very well in the first place. And so if you start seeing poor wound healing, if somebody does end up with an ulcer on their foot, or they step on a tack or a nail, and it takes months to heal that thing, you want to worry or screen the patient for peripheral arterial disease. So what are the main risk factors? We really can get rid of the bottom three and look at this one. Now, it's not exclusive, but smoking increases your risk dramatically for peripheral arterial disease. Same thing for abdominal aortic aneurysm. Smoking, it's not a smoker's disease, but it's close. So there are people that have aneurysms and they run in families and things like that. But certainly patients that smoke are at much higher risk to have peripheral arterial disease. Certainly if you see atherosclerosis in other beds, right? So if you have a heart attack, we need to make sure you don't have peripheral vascular disease. Diabetes does increase your risk, and certainly high cholesterol increasing. I could put heart disease up there, and this would be the same slide, right? So this is not news to anybody. All these things right here that are on this list are the same things that tend to cause heart disease. So how do we test for it? So your doctor may say, well, I've looked at you and I've felt your pulses and your pulses don't feel normal. Let's do something to see if you've got peripheral arterial disease. And certainly the first step is not to go to the cath lab and have an arteriogram, right? We want that to be the last step. So we have a machine, and should be here at Coosa Valley within the next week or so, called an ABI machine. So an ABI stands for ankle brachial index. What does that mean? The pressure in your arm and the pressure in your leg should be equal. So what you do basically is put on, these blue things are basically just fancy blood pressure cuffs. We'll put blood pressure cuffs on your arms, blood pressure cuffs on your legs, and you can see hooked up here. And then we just check the pressures. It's completely non-invasive. It's like getting your blood pressure checked in all your extremities at the same time. There's no needle, there's no sedation, there's no preparation. I mean, you can have it, and it takes 15 minutes or so. And what this will do is it will spit out a ratio. So the normal ratio should be 1, right? The pressure in your arm, pressure in your leg should be equal, 1. And so then we can kind of, as the ratio goes down, 0.8, 0.6, 0.4, the worse or lower the number, the worse is your blockage. So certainly people can have like a 0.8. Some people say 0.9 is abnormal. But, if it's in the 0.8, 0.9, that's mild. 0.6 is more moderate. 0.5, we really start to get concerned. 0.4, usually patients have some sign that they're having tissue that's not being fed properly, whether that's an ulcer or a black toe or something like that. So this is a very simple way to screen people for peripheral arterial disease. And we're going to have that available at Coosa Valley. So the other things that can be done, so let's say you don't pass your ABIs. Well, you failed. You didn't study hard enough for your test. But I'm still not ready to go have anything done invasively. So I want to, is there some other imaging study that I can do to see if I've got problems? So let's actually start on the right side here. So one option is to do what's called an arterial Doppler. So that's an ultrasound. And it's kind of like we do when we do an echo on your heart, or if we're looking at your carotid arteries. And so you can see the arteries there, and then we can see the red is the blood flow. And so we can see, that's a very normal looking ultrasound right there. If it was abnormal, the color would be much more here towards the blue side. And that lets us look and see how much blockage is and where it is. Now, so that's an arterial ultrasound. Yeah, arterial ultrasound. It's like a venous ultrasound, when they're looking for blood clots, except we do it on the arteries. So what this is on this side is called a CTA, which stands for CT angiogram. So it's like a CAT scan. It is a CAT scan, but they do give you some dye so that they can look at your arteries. And so, again, you can see what we saw in that other picture. Here's the aorta. Now, if you notice in this patient, so the gray is pretty normal. You see all that speckly white stuff up there? That's all calcium that is in the artery. So very calcified blood vessels. And so we can come down here and you see these areas of calcium, but there looks like pretty normal blood flow down this left leg. But if you look here in the right leg, you come down here and you see this one, this branch called the profunda goes to the thigh, and this is called the SFA, the superficial femoral artery. And you can see that there's a blockage there, and whoop, what happens there? It's completely blocked, 100% blocked. And then the body has created some alternative flow, and so this blood vessel is actually getting filled in by these little tiny blood vessels over here. So it does give you some blood flow, even though the thing's 100% blocked. It's not quite like a heart attack. You know, with a heart attack, you know, you block off the artery, you're having a heart attack. A lot of times this happens slowly over time, and the patient builds these what are called collateral vessels, kind of like your own little bypass. And so it does provide enough blood flow that you don't have tissue loss, but it's not enough blood flow if you want to, you know, walk up a hill or walk upstairs or things like that. So we can use a CTA also to look at the blood vessels. So what are some of the things you can do before we do something non-invasively, okay? Everything that you can do, you know, the last thing we want to do is a procedure on you. So as I always say, the safest procedure is no procedure, right? So every procedure has some risk. And so we want to be sure that when we're going to do a procedure that the risk it doesn't outweigh the benefit of the procedure. So certainly the most important thing you can do is if you do smoke, stop. I know that's easy to say and it's hard to do. I'm a realist about it because most people I know that smoke for a long time, and it's just part of your lifestyle, and it's hard to quit. But there are methods to do so, and it is really important. Certainly aspirin and statin drugs are helpful, just like they are in heart disease. I can't overestimate this one. There's actually good scientific data that if you get on a walking program, you'll actually improve the blood flow to your legs. So patients that start a walking program, even if they have PAD, even if they have that leg that looked like that person we just showed you back there, if you start a walking program, your long-term outcome will be better. So I cannot emphasize this enough, the walking program. Certainly a foot care program, particularly any diabetics in the room. I know they give you know, every time you walk in, let's look at your feet, let's make sure about your feet. And partially it's because diabetics don't feel their feet, right? They get a neuropathy, so if they stepped on something, they may not feel it. And they may be cooking an ulcer down there and had no idea. And then if they don't have enough blood flow to heal it, then you have a problem. Particularly diabetics, but certainly anybody with PAD really should not go outside barefoot. Okay, wear your shoes. Just wear your shoes, get some Crocs, whatever. Cover the bottoms of your feet so that you don't injure yourself and not know it. And then there is some drug therapy. There's a couple of drugs, one called Pletol, one called Trental. In some patients it's helpful. That's not kind of 100% medicine. You know, if I take that, my problem's going to be solved. But in some patients it does help. So, sorry about this photo, but I think it's very important. This is our enemy. What we want to avoid is amputation, because untreated peripheral arterial disease leads to this. Gee, you got a glass of water? Sorry, I'm getting all choked up. So, people that have peripheral arterial disease, ultimately, if the tissue starts to die, or you develop an infection that keeps climbing up your leg, this is what ends up happening. And so, you're fantastic. Thank you so much. So, our number one goal, while we want your legs to feel better and we don't want them to hurt, we don't want you to be without one. All right? Far harder to do this, and particularly if you have other medical problems, it's much harder to walk around with a prosthetic limb than it is on your own 2 feet. And so, everything we focus on here is to avoid this. This is absolutely our enemy. So what are some of the ways that we can treat peripheral arterial disease? Certainly, in this day and age, we can do a lot with PCA, which is balloons like we do in the heart, and sometimes placing stents. We actually have a lot of new technology now with lasers, which we can kind of laser out the blockage. Atherectomy devices, which actually cut out the plaque. And we actually even have drug-coated balloons now, which help to keep the plaque from growing back. Certainly, if I was given this talk 30 years ago, these two would be gone and this would be your only option, would be a surgical bypass. Now, surgical bypass in the right setting is a good operation. It works, it's fine, but it's an operation. And in some series, there was a risk of 6 to 10% of having a heart attack while you had a vascular surgery bypass. So it's not without its risks. And certainly, even if you get a bypass in your legs, usually at 5 years after you've had that bypass, anywhere from 25 to 40% of those bypasses are closed after 5 years. So it's not, I'm not trying to downplay my surgical colleagues. It's a good operation. If you got no other option, you should get a bypass. If it's the difference between losing your leg or having a bypass sounds great. But it's not, I got my bypass and I'm good for the next 40 years. It's not. And again, people that have PAD many times have heart disease. And so the whole process of getting anesthesia, having operation has risk to it. But it is an option that's out there. So I'm going to show you a couple of cases that I've done over the years. These are real patients. These are not kind of found them on the internet kind of patients. These are everybody that I've treated. Some of these patients actually we've done here at Coosa Valley. So we have a number of, because we're able to do a lot of these stenting procedures and balloon procedures actually here at the hospital. And we're trying to do as many of those as we can here. So this is a case where the patient, so you remember, this is the spine, that's the right iliac artery, that dark line there is the catheter, and we took a picture and you can see what happens right there. The blood flow stops. You don't see any of the aorta, you don't see any of this leg. So it doesn't mean that this is closed and this is closed, it means that this one's closed right there. And so what we did is I was able to get a wire up across there and balloon it, and if you kind of look at that, like hatch mark things, that's a stent that's in there. So we open that up with a stent, and now you can see good blood flow going down that right leg. So we can deal with this, and this was a person who, this was actually a police officer who came and saw me. I originally met him because he had a heart attack one night, and he was thinking about retiring because every time he was in his late 50s, early 60s, he was a beat cop. He liked being a beat cop, but he was thinking about quitting doing it and taking a desk job because every time he would walk or move around, his right buttocks would hurt. And it turns out when he actually came in for his heart attack and I tried to get the catheter to go up here in his legs, I couldn't get it there. So I had to go to the other side to take care of his heart attack. So when he came back, I said, hey, let's fix this. And I'm happy, this is probably, 8-9 years ago. I'm happy to report he was able to stay working and just retired last June and finished out his career like he was hoping to. So, and that hip pain for which he had gotten a bunch of injections and physical therapy and all these things, that hip pain went away. So that was all due to this. So we can deal with simple blockages. So if you look, this is the femur, which is the main bone of your leg, of your thigh. And so you can see this is just a simple blockage right here. This is a sign of centimeters there, so that thing's 1 centimeter long. But it's just like the drain pipe at your house. It doesn't really matter where the blockage is. If it's blocked somewhere, the water's not going down. So if you're blocked up here, it's not getting down any farther. So this was just treated with a simple balloon. I put a wire in there, I ballooned it, and there you can see it's fixed, it's open. No stent, no cutting, no lasering, no nothing. We just fixed it with a balloon, and the patient's leg pain went away. Now this is a case where, so I want to give you some of the limitations of what we do too. I don't know if you can see it, but at the top of this picture, you can kind of see these lines that are just outside the artery. So that's actually an old stent. So stents in your legs are not perfect either. You know, it's not a situation I put it in and you're good for another 30 years. Unfortunately, stents in your legs can block back up. And so this is a case where the patient has developed some scar tissue within the stent. The stent stops right there, but this is blockage that occurred within the stent. And again, similarly treated, we put a wire down there, we balloon it and clean it out, and you can see now good blood flow down the leg. So these are kind of simpler cases. Here's a case of a guy who's a veteran, and he was walking with a cane and limping because his left leg hurt so much. And if you look up here, there's the artery, and it ends right there. And you can kind of see the artery coming in down here. So he's blocked off from here down to here. Now, this is a very difficult lesion to block, to deal with. So you can see, so that dark wire is the wire, and we put a balloon in there. And that's that balloon blown up at high pressure. But you see what we call a smile, or the waist in the balloon. So with that long balloon, I wasn't able to get the blockage open. So then I had to bring in a smaller balloon, a little tougher balloon, and you can see that one didn't work so hot either. And so finally we had to bring in kind of the toughest balloon we had, and under a lot of pressure, which makes us a little nervous to blow it up at too high pressure, you can see it open. And that's what the artery looks like now. If you remember, it was blocked up here and there, but now he's got good blood flow. He doesn't walk with a cane anymore. So, again, similar case. So this is another more complicated case. You can see this artery, it's blocked right up here. We got the balloon down there, we ballooned it, but you can see right in here, the artery looks nice there, the artery looks nice there, but it doesn't really fill in very well there. So when we ballooned this, it turned out that that patient had a bunch of blood clots stuck down in there. So that's a possibility. That's why we want to get to these things sooner than later. And so we ended up putting a catheter down there and dripping in some clot buster medicine. And so she had to be in the hospital laying on her back for 24 hours while this clot buster kind of dripped in. And so when we came back the next day, you can see there's still just a little bit of residual clot right there, that little empty spot, but it's much better than it was. And so then we ballooned that, and so you can see what the artery looks like now. And so we prefer to find them without clot. The problem with blood clot is that blood clot can go downstream and block things up downstream, which actually is what happened. So once I looked down her knee, so now we're now below the knee, and you can see here there's no artery. So the blood clot traveled. Even after the clot buster, the blood clot traveled down into this is now below the knee. Thankfully, we were able to get it back open here, but we really want to try and limit the amount of blood clot because we can't really control blood clot. It's not easy to capture it. And so that stuff will go downstream, and that's what we absolutely don't want. So this is, I think, the last leg case I have. This is a case I did last year. This was a guy on a Tuesday morning who was scheduled to undergo an amputation of his right leg? I think it was right leg. And so I said, well, let's have, and the guy didn't want an amputation, but he had a huge ulcer on his foot, it wasn't healing, and they were worried that, he was never going to heal it. So we brought him to the cath lab, and I took a picture, and you can see the artery is completely blocked right here. And so this is kind of up at about the level of the knee. And if you look, this is his foot. So you can see the foot goes all the way down to here like that. And you can see there's almost no blood flow in the foot. So the arteries kind of stop up here around the ankle. And that's because these little collateral vessels just can't provide enough blood, and that's why he's not healing it. So we were able to get that open. So if you look back, that's the artery here, and now that's the artery here. We were able to get that back open, and now look at the foot. You see how he's got blood flow out into the foot and things? And so that fella has healed his ulcer, and he's still not had an amputation. Now, I'm not trying to toot my own horn. That's not what I'm trying to do up here. But I do want to show you some of the things that we can do without having surgery. Surgery, I mean, going to the operating room, getting anesthesia, having a cut you open operation. This is still a procedure, what we do. It's an arteriogram, but we do it without, not without anesthesia. I'm not trying to say that. We do it, you know, kind of in la-la land, and it's all done through a puncture in your leg. I mean, I'm sure there's people in the room that have had arteriograms before. And so it's much less invasive. It doesn't involve, you know, using a scalpel or anything like that. And we can get these arteries open, and we can help people avoid amputation. We've seen that. That's again. So you can see the stent here. See those 4 dots going across there? That's the stent, and you can see the scar tissue that's formed in there. So this is full disclosure. Stents don't last forever. We were able to open it up, and the patient did well. And here's another case. Last case, patient had a previous stent. You see the stent sitting right there. But really, the whole artery is blocked off, and then we were able to get it open and get blood flow back. Similar case there. So there are a couple of emergency cases. Most of these cases in PAD are elective cases. Hey doc, I can't walk out to the mailbox anymore. My leg hurts so bad. Or I'm waking up in the middle of the night because my legs are just killing me, and I've got to swing them down on the floor to make them quit hurting. Things like that. But there are a couple of things that that are emergencies in your feet, and one is called an ischemic foot. So an ischemic foot means that it's kind of like a heart attack of your leg, right? You had a blood clot that acutely formed in there. And so we talk about the 5 P's of an ischemic foot. So it will be painful, you'll have pallor, it'll look a lot lighter than the other foot. Paresthesias, that means you'll kind of have pins and needles going in there. It will be pulseless, I mean I can't feel a pulse. And many times you'll have paralysis, you can't move the foot. So if you have this acutely painful foot and it looks really light colored compared to the other leg, and particularly if you don't have a pulse and you can't move it, that is an emergency and needs to be dealt with immediately. The other thing that really is an emergency is if you have an infection in your foot and that infection starts climbing up your leg, and if you don't have blood flow, you're not going to heal it, and you're going to lose that leg if you don't get it looked at right away. So ulcers on your leg, whether they're from arterial disease or venous disease, need medical attention. You know, people like to doctor stuff on their own, and I'm fine with some of that. But if you've got breakdown of your skin on your foot or on your ankle, then it needs to get looked at so that you can get to the cause of it and get on the right treatment. So, what can you do so I mean, the last part of this talk is mostly to kind of show you what we can do when you have PAD. It's what I don't want to do. I don't want to do a procedure on you. I don't want to, have to send you for an amputation. I don't want to do any of that kind of stuff. I want you to realize that you may have PAD, but there's a lot that can be done before we ever have to stick a needle anywhere near your body. Number 1, quit smoking today. That is, again, get rid of this bottom part. Don't smoke, please, 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 please. It does increase your risk for this, and I know it's hard. Number 2, a walking program. Not just for PAD, but walking program for everything is helpful for people with joint disease, for people with muscle problems. The more you're active, the more healthy you're going to be. So even just a simple walking program, you don't have to go join the gym and get on the elliptical, and I've got my personal trainer and all that stuff. And if you have all that, I think it's great, but you don't need it. Just, walk around the neighborhood. Walk around your backyard. It doesn't matter. Just start. And if you're going to start, do 10 minutes a day, 3 times a week, and build up from there. But a walking program is so simple. It doesn't cost any money, and you can do it just about anywhere you are. I know patients that like to go to the mall, patients that like to go to the Y. Find a couple of friends who want to start walking with you, because it's always easier to do it with a group than it is by yourself, particularly when it's cold this time of year. I think also important, get screened for PAD. Does everybody need to be screened for PAD? Not necessarily, but have your doc feel the pulses in your feet. If you have normal pulses and your feet feel fine, you don't need to go have a screening test. If your feet hurt, Your doctor says your pulses don't feel normal. Hey, I've got some of these funny skin changes in my legs. What's going on with that? Then get screened. Screening is so easy. It takes 15 minutes. We can do it at the hospital. We got an ABI machine, and if your ABI is normal, you're done. All right? You don't need anything else. You don't have to proceed to any of those other things.
Excuse me, is the ABI machine one that tests your legs and
Your legs and your arms. That's right. That's right. And it is. It's like a fancy blood pressure. So I think a bunch of you got your blood pressure checked back here. It's like getting your blood pressure checked on all four extremities at the same time. It's really no more difficult than that. And so, but get screened. I think the biggest problem that we have is that this problem goes underappreciated. You know, again, people kind of just say, well, I guess my legs are supposed to hurt somewhat, as I age. But no, they shouldn't. And we need to know about this, because if we find this early, then you don't have to have all this other bad stuff that I talked about. So that's my presentation, and I'm happy to take any questions from the audience. Yes, sir.
Oh, I'm a heart patient and I have diabetes.
Yes, sir.
Now my upper legs and hips hurt. From my knees down, it feels like I got stockings on, and the bottom of my feet, my toes are numb. So where do I stand there?
So it's very common in diabetes to have a situation called peripheral neuropathy, diabetic peripheral neuropathy. The classic description of it is a sock and glove, where somebody feels like there's a glove or a sock on the bottom part of their foot. And so what you described from your knee down is classic for peripheral neuropathy or diabetic neuropathy. Now, that can cover up PAD, right? Because you don't tend to feel your leg. And so certainly if you're diabetic, you're a heart patient, you are the poster child for somebody who should get screened. And be sure that you don't have PAD, because you're at risk for it because of your other medical problems. So I would screen you. I would absolutely. Now, first thing I do is have you take your shoes off, take your socks off, and I feel your pulses. And if your pulses in your feet are normal, your chances of having significant PAD are extremely low. Extremely low. So that's even cheaper than an ABI. Put your hands on people's feet and feel their pulse. Ma'am?
I have something so strange that I don't know how to explain it in my left leg. I feel like maybe you can feel that little leg footage running up down here, go away to that, and sometimes I'll have it behind my knee.
Sure.
And I've never told the cardiologist about it, but sometimes they'll mistake their day, sometimes they'll go, is that anything I should
Now, that tends to be most likely more on the venous side of things. If you remember at the beginning of the talk, because your veins will sometimes fill up a little bit more with blood and be a little bit emptier with blood, and so you may feel...
You feel that like a little rivulet running down.
Yeah, it's like a little, it's a superficial vein that you can feel. So that tends to fall more on the venous side of things. And, you know, generally the in a nutshell, without getting going off into a whole venous talk, you know, keeping your legs elevated when you sit, watching your salt intake, and, you know, compression stockings help. Now, you know, the downside of compression stockings, besides being ugly, uncomfortable, and hard to get on, they're great, you know? And so, you know, everybody says, oh, just wear some compression stockings. Oh yeah, and it gets to be 97 degrees in Alabama in the middle of the summer. And so compression stockings they work, but they're difficult. It's like putting steel girders on your legs, you know? And I have a lot of patients who can't put them on themselves. You know, they're just too hard to get on. Now,
That's the reason why we come at certain times.
it depends on your physiology that day.
I work a lot.
Yeah, so maybe if you're on your feet more, you may have more of it. It's hard to know. Now, they do make there are companies now that make compression socks. They're not quite as effective as a compression stocking, like a prescription one, but they do provide some support. They're a lot easier to get on. And now they're starting to make them in all kinds of fancy colors with polka dots and paisleys and stripes, and so people can wear them. And then, you know, people don't know that they're wearing compressions, right? So, you wear compression stockings, sorry about that. But now you can wear, they just look like regular socks. And they are fairly effective. I mean, it's not as good as a compression stocking, but,
Is that something that I have to be concerned about, like if it comes to goals?
No, I would not. Unless it starts to really, really bother you. You're welcome.
One more question, okay.
How rare is it for someone to have 4 massive aortic aneurysms?
That's pretty rare.
My husband had 4.
Yeah, so
10, 8, and 7.
you worry in those cases about some sort of genetic issue. Now, it doesn't prove it.
We had began to suspect it.
Yeah, and so when you start popping out aneurysms all along in different places along your aorta, it kind of tells you that the tissue of the aorta is not very strong. And so in my mind, I would say, why? Why is that? And, so there are some kind of, uncommon diseases where people are more prone to having aortic aneurysms. Like there's one called Marfan syndrome, that's kind of the most well known. And that's a connective tissue problem. So your aorta is made of muscle and of connective tissue. And if the connective tissue doesn't kind of hold it together, then I think the most important thing, there's 2 important things in patients like that. You got to be vigilant and watch out for more aneurysms as you go along. And when you worry that there may be some potential genetic issue, is maybe screening people in the family sooner. I think Medicare says let's screen you at 65. When you come into Medicare, I think they pay for an abdominal ultrasound to screen you for a AAA. If you've got what sounds like a potential genetic problem in the family, I would screen that patient a lot sooner than that.
Well, we didn't find anything in the family, and we didn't even know he had them. He had been healthy, except just really tired.
It's particularly uncommon.
The one in the leg popped out. We were thought we really had a big knot right in the bend of his leg.
Yeah.
And when we got into the doctor, they found 3 more huge ones.
Wow. So that would be my concern on that. Yeah.
All right, let's give Dr. Schultz a big we get our marketing team to come and let's give out our door prizes. I know one thing Dr. Schultz said today that got my attention. I hope it did yours too. How many times do we try to diagnose ourselves? And so this morning when I got up and my hip didn't really want to work and my leg didn't really want to work and I'm thinking I'm getting older and I'm thinking it's arthritis and I'm thinking I might need a knee replacement, hip replacement. You know what, guys? It could be something else. So let's pay attention to signs and symptoms and let's get to our primary care, get to our cardiologist, get to who we need to make sure we are heart healthy. And you know what? Our feet are made for walking, so that's what we need to continue to do. And this is a great little plug for this. You may have seen or know. We talked about you can go to the mall and walk. Well, we really don't have the mall here. We got some great walking tracks. But the hospital actually has what we call, or we're cutting the ribbon on this Thursday, the John Newberry walking track inside the hospital. So you can actually come to the hospital and you'll find along the floors a trail that you can make throughout the hospital to get that walking in. So it's probably not where you thought about going to walk, but guys, I always say, come in, open your eyes, minister to somebody along the way, and hey, after all, go to the Hickory Street Cafe and have lunch when you're done, right? So it serves a lot of purposes. So when you come into the hospital, look along the way and you'll see the trail, as we call it, on the floor. So, or come Thursday at 10 and you can celebrate with us as we start that new tradition at Coosa Valley. So it's a great way to promote that, as we heard him say we need to keep walking. And you might know, if you knew Mr. Newberry, he did that for years. He came in and he walked throughout the hospital and kept himself